My name is George Cyberry. I'm a pediatric infectious disease physician. I work at USAID, part of the PEPFAR work based in Washington, D.C. And it's a real pleasure to take this virtual walk through some exciting posters. This is poster tour number 4, and the theme is pediatric HIV care and monitoring. So we have several posters, and so what I thank you very much for displaying those. So what we'll do is more or less in order, depending on availability of our poster presenters on the call. We'll turn to each one. I'll have the organizer project the actual poster, and our poster presenter I'll ask to just spend a couple of minutes taking us through the highlights. And a note to our poster presenters, if you say as you present something like methods or results, then the organizer can zoom in on that part of your poster to make it easier for us to see. So we will just spend a couple of minutes, again, asking the poster author to hit the highlights of the findings and conclusions. And after each poster then is presented, I'll have a couple questions, and I'll welcome questions from the group. So please do use that chat box for questions. And we have several minutes for each poster, and then our time will just fly by and we'll be up. So why don't we go ahead and get started? Our first poster, The Changing Face of Pediatric HIV, a review of the evolving clinical characteristics of a pediatric and adolescent patient clinic in Johannesburg, South Africa. And this is poster number 45. So Josephine Keal from South Africa is on the line. So please go ahead and project that poster. And Josephine, I'll ask you to just spend a couple of minutes taking all of us through the highlights of your poster, please. Please come on stage and go ahead.
Okay, hello everyone. Can you hear me clearly?
Very clear, yes. I can't see your poster yet though, so hopefully that'll come straight away. There we go.
Sure, there we go. Okay, so my name is Josephine Keal. I'm currently working at Ntombenhle Services and Research Unit. It's a pediatric and adolescent HIV clinic based in Johannesburg, South Africa. The clinic has been operating since 2003, and this allowed us to compare the evolving clinical characteristics of pediatric and adolescent patients living with HIV over the last 15 years. So how we did it, with the methods, we analyzed prospective longitudinal data from the clinical visit database. So we assessed the cohort by taking cross-sectional samples from 4 different years, namely 2005, 2010, 2015, and 2020. For each year, the age, nadir CD4 count, and duration on ART, as well as the BMI, were compared. With the increase in number of adolescents living with HIV globally, there has been a growing concern about the incidence of non-communicable diseases and the effects of long-term ART exposure on the subpopulation. So in terms of our conclusions and what our results showed us, these data showed us the changing face of the HIV pandemic, notably a large shift to adolescent population. You can see, I think it's a top graph. I don't know if we can zoom in on it, if possible. It's okay if it's not possible.
It's coming.
Okay, cool. There we go. So it was just, it demonstrated quite nicely with that graphic. You can see a yellow line was our age 15 to 20 years. And you can see how that rose really rapidly, and our 0 to 5 years has dropped quite dramatically from 2005 to 2020. Secondly, and a more immune competent cohort at initiation of treatment was seen. So this is, I think, the second graph, if we can go down to that. So yeah, that was just the nadir CD4 count. So as you can see in 2020, it was, you can see that the CD4 count in blue is less than 200. So there were far fewer patients with a nadir CD4 count at initiation of less than 200 in 2020 compared to 2005. So, and importantly, children living with HIV are living longer, and the number of children who classify as overweight is rising. This is particularly important to us at the moment as we are busy rolling out dolutegravir containing regimens, and as we know, a potential side effect of dolutegravir is weight gain. So in summary, we need to start looking towards the long-term consequences of prolonged treatment and the management and prevention of non-communicable diseases in our adolescent cohort. Thank you.
Great. Josephine, thank you so much. It's really such a nice poster, and in so many ways, just the success of both prevention and treatment of HIV in children coming to fruition, and nicely demonstrated. I wanted to ask you, are all of these children thought to have perinatal infection, or is there a mixture among these adolescents that includes some who had infection from other modes of acquisition?
So by and large, our clinic is perinatally acquired. We actually, there are a few cases where there's been other forms of transmission, but we don't really have a large proportion of adolescents who've been initiated at our clinic. The vast majority of them have been with us from birth or infancy all the way through. Excellent.
And when you talk about CD4 nadir, is that the nadir in this year that you look cross-sectionally, or is that a lifetime nadir?
It's a lifetime nadir, so yeah.
And so even though that's gone up, it's still being weighed down, isn't it, by the big bulk of kids whose nadir can never go higher than what it was in their past. Did you look at the nadir among those starting or being diagnosed, I should say, within each of these 5-year periods?
Sure. That's actually a very good question. It might be something to look at. We didn't really, but it might be interesting to pull that data separately and see if there has been a trend or, yeah.
Awesome. I think it just may show an even more dramatic improvement in where these kids are starting in terms of immune function when you don't have all of history to bring your average down.
Sure, definitely.
And I see some questions from the chat, and so let me just ask a couple of these. What's the average proportion of children aging out of the pediatric age group? Have you looked at your sort of proportion of kids who are 14, about to turn 15, and age out of the conventional pediatric group?
Sure, not really. Our clinic is it's quite unique, I suppose, in a lot of the clinics in South Africa anyway, in that we manage pediatrics and adolescents all the way through, so that would be, again, something that we could definitely look at. But yeah, we haven't really pulled that data separately at all.
Do you have the data in a sort of a EMR or some way that you actually know exact age for each of the kids that are in the cohort?
Yes, we do have. We're extremely fortunate in that from sort of the onset of our clinic, we had someone who was very, keen on getting an EMR going. So we have relatively clean data from, 2003 actually all the way up till recently. That everything's relative, but it's a really nice, really nice database.
So that sounds extremely valuable. And we've been thinking a lot about how to understand with these kinds of demographic shifts like you've shown among children and adolescents on ART, how we anticipate the numbers in each of our conventional age groups year to year, since the assumption that it'll be the same number, say, who are 14 this year as we had last year, is probably not a valid assumption given what you're showing. And so maybe if you could look at those data and say, right by age, 1 year age band, what percent are in each of those groups, it might help you anticipate what those shifts will be in the coming years.
Definitely.
Well, that's great. All right. Well, that was fantastic, Josephine. Thanks for being our, first one up and making it work so well.
Sure. Thank you so much.
Many, many thanks and congratulations on a nice poster.
Thank you very much.
All right. Let's see. So who shall we have? So next will be Kaylee. Kaylee, am I saying your name right? You can come on deck. Let's see if Kaylee can turn her mic and her camera on. Well, while she's doing that, why don't we go ahead and project her poster in optimistic anticipation that she will succeed. Great, and let's shrink it a little bit so we can get the full picture. Yeah, this is an exciting poster. Impressive to just be able to follow kids for this many years after their initial participation in a trial when they were infants. Kaylee, are you, you're getting directions there in the chat box. Press the blue button. Aha, Kaylee, that looks like we've got success. We have liftoff. How are you?
I'm good. How are you?
Good. So welcome. And we see your poster here in front of us, cognitive outcomes at 7 and 9 years after the shared trial. And if you, as you are, just spend a couple minutes giving us the highlights of your findings. And if you mentioned the section of the poster, the person who's operating this for us can then hone in on that if you like. Any questions?
No. I'll just take you through it.
Great. Go ahead.
So in the study, we compared and described the cognitive performance of, the children that were randomized into one of the 3 intervention strategies employed in the SHEAR trial. So we described their performance at 7 and at 9 years of age. I don't know if everybody knows what those 3 intervention strategies were. I'll just tell you quickly. It was those children who had received immediate ART initiation and planned interruption at 40 weeks. And then the second group was those who received immediate ART initiation and planned interruption at 96 weeks. And then the third group were those who had received deferred ART initiation until clinical and immunological disease progression. So for participants assigned to the ART 40 and 96 weeks, ART was restarted after interruption and according to clinical or immunological criteria. Our design also included 2 comparison groups, children who were HIV exposed and uninfected, and children who were HIV unexposed and uninfected. To fully understand the impact of HIV on the developing brain, we conducted 3 sets of analyses. The first of the models, we compared an HIV positive group to an HIV negative group. So the HIV positive group was the combined ART 40 week and 96 and the ART deferred group. And of course, the negative was the HIV exposed, uninfected and uninfected. And the second model compared an ART early group to the ART deferred group and compared them to the HIV uninfected groups. And the last model compared all 5 groups against each other. So I'll just quickly take you through the results there. Analysis comparing the cognitive performance of the HIV positive and HIV negative showed that at both measurement points, the HIV positive children performed significantly more poorly compared to the HIV uninfected children on measures of executive functioning and auditory working memory. And the second set of analyses comparing the ART early to ART deferred and the HIV uninfected confirmed the results I just described as well, because here the HIV uninfected children performed significantly better than the HIV positive children, also on a measure of auditory working memory. So these results really confirm our hypotheses around the impairing effects of HIV on cognition. And of course, it's consistent with previously published data. What's important to remember here is that even though more than 85% of these HIV-infected children were virally suppressed at the time of testing, it appears that the virus still interferes with their neurodevelopment and has affected major areas of cognition. So, for instance, deficits in executive functioning, which is what we saw here, is that we expect these children to have difficulties with regard to planning, monitoring, and decision-making. And for example, the deficits that we see now that they have deficits related to working memory. And we know working memory predicts reading and math achievement. And therefore, these children may, in fact, underachieve educationally. Then lastly, when comparing all 5 groups, this particular set of analyses didn't actually confirm our hypotheses related to the effects of early intervention, because here all of the ARD40 with the ARD96 and the deferred had similar results and similar scores at both measurement points. But this is in fact consistent with the work presented by Dr. Barbara Lawton when she assessed these children at 5 years, which again demonstrates that regardless of the precise nature of intervention, limited ART interruption, with strict clinical management or monitoring in virally suppressed children who start early treatment, it doesn't really negatively impact later cognitive performance or outcomes. And our findings also support the original SHEER trial data, which reported that early time-limited ART seems to be a safe course of treatment.
Perfect. Great, Kaylee. This is a complicated trial to begin with, and then the follow-up, right, is also complex. So thanks so much for taking us through that. And, I think also being able to follow kids for this long and with these kinds of intensive studies is just remarkable. So thank you again for being able to manage that. I think it was interesting to me that, for instance, that the working memory issues seem to be, I looked to kind of understand whether the HEU children, those HIV exposed uninfected, did they look more like HIV unexposed, or did they look more like HIV and early treated? Did you see anything that stood out to you as HEU looking like they had evidence of a problem, even though they weren't infected, obviously, themselves?
When we compare the early versus deferred treatment group, that's where we actually noticed, yes, that the uninfected group significantly performed better on working memory tasks compared to all the other groups. So the HIV exposed group included. So I think,
great. So thank you for highlighting that, because I do think when these days, right, the number of kids who are HIV exposed uninfected far outnumber, right, the number of HIV infected infants. And yet that may be a sign that we have more work to do in understanding potential problems that they may have. But here's another question for you, Kaylee. The findings seem to be, one sort of problem here, but then a different problem there. How do you sort of decide whether this is just biologically plausible because development changes over time, or whether we're doing so many comparisons that we're just having some chance findings here and there? Talk to us a little bit about how you decide between those two explanations for these kinds of findings.
Well, I suppose it's always possible for chance findings, but here I think what we need to look at is the time period that we've selected to assess these kids, which is 7 to 9 years, which is a critical period of brain growth. It's the period of time where the foundations of adult architecture for brain is being developed in these children. So it's the period of time where we would expect to find differences because they're heading to school. Teachers, parents notice differences at this stage of their children's lives. So this is the period right before adolescence. So this is the period where we want to pick up if there are any problems and potentially intervene before it persists into adolescence, if that is what's happening.
Terrific. Great. Well, thank you for letting me ask my questions. I don't see any in the chat, Kaylee, so I think we'll probably thank you and then move on to our next poster.
Perfect. Thank you very much.
Thank you so much. Great. So next up, Immaculate, if you could go ahead and hit your green button so that we can see your face and hear your voice. And Kaylee, you can hit your red button and that will get you off the screen.
Okay.
There we go. Hi, Immaculate.
Hi.
We could get Immaculate's poster up there, please. That would be wonderful. So Immaculate's going to talk to us about this poster, Retention and Viral Suppression Among Child Caregiver Pairs Enrolled in Family-Centered Differentiated Model of Care in Kenya. So Immaculate, again, just take a couple of minutes to take us through the highlights. And if you want the operator to focus in on a graph or something, just say it as you go. Over.
All right. Thank you, George. My name is Immaculate from CDC Kenya, and I will be talking to you about retention and viral suppression among child caregiver pairs enrolled in family-centered differentiated model of care. Kenya implemented a differentiated model of care for PLHIV in 2016, but children lagged behind because there were fears that their outcomes will be poorer, that they need to be seen more frequently in their clinics, and that their weights were changing, and therefore there were a lot of fears of giving them longer TCS. But in 2018, we looked at the family viral suppression, and like Lynn highlighted earlier in our opening remarks, that pediatric HIV is a family disease, and we looked at how do child caregiver pairs, look like in terms of their outcomes, and we realized that if you look at children and their caregivers, and you look at their outcomes in terms of viral suppression, we realized that up to 70% of children who are virally suppressed, their caregivers were equally virally suppressed. And therefore, we were able to cohort stable child caregiver pairs, 4,611 of those. And out of those, our outcomes of interest were, viral suppression and retention. And we looked at their data after being enrolled in what we call Papa and Mama Care Family-Centered Differentiated Model of Care, and see what were their outcomes after 12 months being in that model, where they were getting about an average of 3 to 4 clinic appointments. And what we noticed is that actually their retention remained very high at almost 99.5%, and the overall viral suppression was equally high at 98%. And we conclude that it is possible to get, near universal retention and viral suppression for child caregiver pairs who are enrolled in, longer TCS, getting longer appointments for as long as they are stable at baseline. And probably moving forward, we may want to consider this cohort to much longer TCS, like 6 months. And that will allow clinics to focus on stable children who are sicker, who need more time and effort from the healthcare providers. Thank you, and over from me.
Great, Immaculate. Thank you so much. This is so exciting to see. And I just love the idea that, families, who've been able to succeed with their treatment, they tend to succeed together. And where they're succeeding together, they don't need to be coming in as often. So this is really a nice demonstration. And this was a 3-month interval, Immaculate, and it sounds like you're thinking about moving to 6 months. Is that right?
Yes, for the stable pairs, yeah.
And for children too, right?
Yes.
Excellent. All right. Well, Immaculate, that was such a clear presentation, and I think the message here is clear too. It's something I think people can take up very readily in other programs, don't you think?
Yes, I think so.
Excellent. All right. Well, I see our time is short because we got started late. So with your indulgence, Immaculate, I'm going to thank you, and then we're going to move on to the next poster.
All right. Thank you.
Thank you so much. All right, Desiree, you're up next. We'll pull your poster up as you push your button and you get ready to join. Well, let's make that a little bit. Okay. Desiree Dahourou. Yes, great. So please go ahead and give us the highlights of your poster about HIV, about viral load coverage and suppression in the West African cohort. Over to you.
Okay, thank you. So my name is Desiree Dahourou from Burkina Faso. On behalf of the ID West African Group, it's my pleasure to present our study on access to viral load monitoring and poor virological outcome in children and adolescents living with HIV in West Africa. Background, you can say that reducing the pediatric AIDS-related mortality requires improving timely antiretroviral treatment initiation in HIV-infected children, retaining children and adolescents living with HIV in care, access to routine viral load monitoring achieving and maintaining viral suppression. So the objective of this study was to assess the progress towards the third 1990 UNAIDS target in the ID pediatric cohort. For the method, the PWADA cohort is an observational prospective cohort including 10 clinical centers in 5 countries. HIV-infected children and adolescents were included in this study if they have a confirmed HIV diagnosis, age less than 18 years, and are naive, and enrolled between 2004 and 2018. The main outcome was access to viral monitoring 6 months after IRT initiation. The secondary outcome was virological suppression, defined as first viral load less than 500 copies 6 months post-IRT. We present here the cumulative incidence and factor associated with accessing to viral suppression using regression model with death and loss to follow-up as a competitive risk. For the result, please, poster.
Continue. Go ahead, Desiree.
Okay. So a total of 5,475 children and adolescents living with HIV initiated on IRT at the median age of 5 years. During the follow-up, 14 children died, 22 were lost to follow-up, and 55 had at least one viral load measurement after 36 months on IRT. This is presented on the figure. In the multivariate model with death and loss to follow-up as a competitive risk, adjusted for center, gender, clinical stage, and CD4, children aged less than 10 years were significantly less likely to access to viral load compared to those aged 10 to 15 years, as well as children and adolescents enrolled before 2016 compared to those enrolled later. Among those with viral load measurement, 53% were virological suppressed. Viral suppression was less likely among those who initiated on IRT before 2013 compared to 2016. Finally, among the 2,088 children in active follow-up, 84 had a viral load measurement, among whom 56 were suppressed. So in conclusion, in the PWADA cohort between 2004 and 2018, access to viral load monitoring tested was loud and viral suppression suboptimal. Additional support is needed for children and adolescents living with HIV on IRT, including improving access to viral load testing and the strengthening of their treatment adherence. Thank you for your attention.
Thank you so much, Desiree. And really heartening to see that 84% viral load coverage in the most recent evaluation of your current cohort. You know, I noticed that both younger age and distance having to send a specimen to a reference lab were risk factors. And I wondered if you're using DBS, dried blood spots, for viral loads as a way to overcome difficulties with drawing blood on young kids and for specimen transport issues.
Okay, thank you. For this study, the viral load testing depending for the routine data collection tools on the clinical site, but most sites use blood sample, not DBS.
Yeah.
And in some clinical sites, we have a lab tests available on site, and for those, they need to go in the other lab for testing, for viral load testing. So it's not really the same the same procedure for each site.
Very good. All right. Well, Desiree, thank you so much. Very nice poster. Thank you so much for sharing these results with us.
Thank you.
All right. Next, we have Cyrus. So Cyrus, go ahead. Desiree, you can press your red button. Cyrus, you can push your, I think it's blue button or green button to get started. Oh, there he is. Okay. And we'll get your poster showing up here. Just take us through, try to do it in just about a minute, the highlights, if you don't mind, Cyrus.
Yeah, sure. Very quickly. So we were looking at utilization of viral load information for adolescents and young adults living with HIV in Kenya. In the background of having the WHO and local guidelines recommending that adolescents receive viral load tests within every 6 months. And for those who are unsuppressed, they receive adherence support and a repeat viral load done within 3 months to rule out treatment failure. And then this determines whether someone gets treatment modifications. So using program data, data collected between April 2017 and May 2019, we looked at utilization of this data for the care of adolescents and young adults. We abstracted about 17,000 records for 17,000 adolescents, beg your pardon, and over this period. And out of those, 4,010, representing 23%, were virally unsuppressed. And only 8% of those who were virally unsuppressed went ahead to have a repeat viral load within the recommended 3 months. And only an additional 21% actually got a repeat viral load within 4 to 6 months. So these are very low numbers. For those who had a repeat viral load, the median time from the first to the second viral load was 6 months, again, coinciding with the recommendations for everyone getting a viral load anyway. 58% of those who were unsuppressed and got a second viral load actually had an unsuppressed second viral load, meaning that they had viral treatment failure. And only 32% of those went ahead to have regimen changes. And though we don't expect that everyone would have regimen changes, we expect a more substantial number to do the same. So big gaps throughout the whole viral load monitoring cascade. And a few recommendations to target these specific issues would be integrating in patient records reminders to health providers to make the requests and to take action when they actually get these results. And that would improve the health of our adolescents.
Excellent, Cyrus. This is such an important analysis. We do all this viral load testing, but if we don't use it, is it really going to be that useful? Are you required to spend 3 months working on enhanced adherence counseling before getting the next viral load?
So that has been very contentious because the WHO does not give that requirement. And looking through most of African countries' guidelines, we had to do that. They've actually added that requirement that we will not proceed with anything until we've got adherence that is good. Achieving good adherence is a nightmare in the adolescent group, which means that most of them will never get the repeat viral load anyway. So rethinking those clauses in the guidelines that require good adherence before repeating the viral load should be something that is considered urgently.
Great, and that Immaculate's making a comment along that effect. And how much? I wonder how much of a delay in turnaround time for that first viral load result contributed to having the second viral load result not sent till more than 3 months from the first.
Actually, what is interesting is the period between sample collection and the result appearing in the dashboard was a median of 21 days, or was a median of 15 days, sorry, which is a big improvement from what we had previously. I think the last, looking at 2015, we had about 28 to 40 days. So 15 days is not so much. It could be improved, but it's not so much. The big issue we realized could be that result being available at the dashboard to the patient receiving that result. And that again goes back to the gaps in care in the clinic itself. Great.
All right, Cyrus, I think you got a lot of good stuff here, but it sounds like you have a lot of work to do to make this work right.
Sure.
Great. Thank you so much.
Yeah.
All right, Cyrus, you get to push your red button, and then Philisiwe, you get to push the blue button to come on. Great. So this is our final poster presentation on point of care early infant diagnosis. There's Philisiwe. And I'll turn it over to you. Welcome.
Thank you, George. Hi, everyone. I am Philisiwe Khumalo from Elizabeth Glaser in Eswatini. I'll be presenting to you some findings from our study where we were assessing clinical outcomes of infants that were identified HIV positive at birth through routine point of care in three high volume maternities in the country. This was a pilot program in Eswatini which was conducted between August 2017 and June 2019. We were piloting point of care testing at birth. So following that pilot, we sought to assess clinical outcomes, including survival of HIV-infected infants that were diagnosed at birth. So this was a retrospective cohort study where we followed the HIV-positive children that were identified at birth. We followed them for at least 12 months through 31 March 2020. For the children to be included in the study, they had to have been tested through POC EID in the 3 maternities that were piloting birth testing. They had to have tested HIV positive and would have reached 12 months in HIV care by 31 March 2020. We abstracted the data from national electronic databases and also triangulated it from health facility-based registers, just to make sure that we had a complete data set on the children. And as I've mentioned earlier, that it was just purely a descriptive study where we summarized data through frequencies and proportions using SPSS. So in terms of the main findings, a total of 30 infants out of 31 that were identified HIV positive at birth were initiated on ART, and one of the children died before they could be initiated, and most of the children received lopinavir-based regimens, but there were also 20% that were started on MVP, and 10% were still on MVP at the age of 12 months. And despite being on ART, the mortality in these infants that were identified as infected at birth was high. At 12 months, 5 out of the 30 infants that were initiated on ART had died. And when we looked at our national records, we saw that the overall mortality amongst the children was a bit high compared to mortality in children that are less than 2 years in the country, and it was 3.5% in 2018. Then when it comes to viral load suppression, that is viral load less than 1,000 copies per mil at 6 months, 87% of the infants that were identified HIV positive at birth were suppressed, but this rate decreased to 71% at 12 months. Again, these rates were lower when we looked at the rates among children that were less than 2 years in Swatini in 2018, where the rate was 93.7%. Of key importance and conclusions from this study is that birth testing, it identifies a high risk group of infants for mortality with suboptimal viral suppression, and it would be good for programs to make sure that they use higher potency ART regimens, particularly integrase inhibitors, to assist more rapid reduction in viral load and potentially decrease mortality. Thank you.
Great, thank you so much. This is a sobering reminder that it's not just about the diagnosis, that that these infected neonates are at high risk of death and difficult to get the kind of treatment outcomes even when we do start treatment. Thanks. So I see that Immaculate's asking if the causes of death were just included some kind of the non-HIV related neonatal causes of death, or were these mostly infections and things that you attributed to HIV itself?
Unfortunately for this study, we didn't collect the causes of death, but of note is that even if you look at figure 1, most of the children, they died early in the early after diagnosis. Most of them had died by 3 months, which is why when you look at figure 1, you can see that at 6 months, 4 of the children had already died, and there was only 1 additional child that had died by 12 months. As much as we didn't collect the causes of death, we could infer and say that having them being infected very early in life could have contributed to their mortality.
Indeed. And I'll ask one quick question. These were all children diagnosed by 3 days of life, but they didn't start treatment till 2, 3, 4 weeks of age. So if they're being diagnosed so early, why weren't they started right away?
The program was piloted in high volume maternities. So there were challenges in terms of making sure that the children are initiated early, mainly because after delivery, most of the time, the woman would usually just want to leave the hospital and go home with their newborn babies. And additionally, in Eswatini, the father of the child is the key decision maker when it comes to what could be done for the infant. So most of the women would want to consult with the fathers before they could make any decision on initiating the child. It also talks to the fact that even some of the women themselves had not disclosed their HIV status to them at home. So there were those expressed fears from the program data in terms of saying, fine, I've tested, but initiating that will complicate my life at home. So those are some of the things that came through the program data in terms of initiating the children. And then there was also a weak linkage and referral, which is something that was noted and needed to be improved. We have a few centralized maternities in the country, so most of the children, when they leave the maternities, they go to different clinics. Then we realized that the follow-up was not as strong, so we ended up tracking the children for initiation, ended up taking longer, thus getting them initiating longer afterwards.
Okay, very good. Thank you, Philisiwe. And I'm noting Desiree's question was the same as mine, so I'm glad that you answered that. And hopefully we'll see that viral suppression for infants gets better when pediatric dolutegravir gets widely implemented, but it won't correct the problems of what you have just described, which is this high risk of mortality very, very early on, potentially, and the need to have the social context right for women and families to be willing to start their infants on treatment on the same day that they're diagnosed. So thank you so much. And thank you to everybody. Thank you for everybody who presented and attended. And with that, we will turn it off.